many. And before we discuss those, we need to discuss about what exactly is the patient going through. So this is corneal topography, is placido-based, which basically images tear film. And you can see in a normal subject, across all the time zones, you can see that there's no fluctuation or change in the surface irregularity. But when you look at a dry eye patient, you can see as time goes, they get an irregular tear film, and that causes a change in not only their tear film, it causes a change in the refraction. So if you see here, this is over time, they're showing you how much of a change in refraction you can get with someone who's dry eye. So someone who's mild dry eye right in the start so the stars that you see at the bottom, they're blinks. So you get this mild change in refraction. But when you get this severe dry eye cases, like you can see here, you see huge fluctuations in their dry eyes. Okay, so you can see huge fluctuations in their dry eyes. And up to about 1.5 diopters of change you can see in someone who is severely dry eye. Now there's many tests that you can do, like a non-invasive breakup time, but if you don't have access to a non-invasive breakup time, you then have fluorescein breakup time. And it's not just the breakup time that's important, it's the position of the breakup as well. So, and we'll discuss this as we go through the cases. Then you have something called meibography, where you can see the morphology of the meibomian glands. And then very few centers have this, but you can then go on to do something called in vivo confocal microscopy, where you can see on a cellular level exactly what's going on with corneal nerves and corneal epithelium, stroma, and all of that stuff. And we'll go through this in all of the cases as well. So this case, this was a 26-year-old patient that came to us with and wanted to undergo LASIK. Her OSDI score, when we looked at it, was 69.4, which characterizes into severe dry eyes. And when we looked at her on examination, she had this severe subsurface haze. So that talked about that after Athens protocol, you can get haze, but these people have haze pre-operatively if you look at them at the slit lamp. And she has SPKs and a fluorescein breakup time of only 1 to 2 seconds, where it should be about 12, 14 seconds. So then, this is the slit lamp image. Here you can't really see anything because you have to make a slit. Then we did a confocal. So you can see this is fairly normal epithelium. This is hers as well. It's just at another location. Then you can see all of these whitish opacities. These are inflammatory markers on her cornea. So there's actually inflammation undergoing in her cornea already. If you're going to do LASIK on it, you're going to actually make that inflammation worse. And what that will do is it will not let the epithelium or the nerves come back properly. And if you look at other images in her, you can actually see immature epithelium cells, so nucleated epithelial cells, which you're not supposed to see. Then when you go to the subbasal nerve plexus, you can see all of these sort of neuroma-like pictures, or cut corneal nerves, or corneal neuromas. We were confused as to what they were, but as soon as you see this, we were like, you should not undergo LASIK. Because how these nerves are going to react afterwards, we have no idea. But this person was incredibly motivated to undergo surgery. So what we did was, we put her on Pred-4 2-hourly drops for 2 weeks, then we gave her preservative-free hyaluronic acid, hourly to 2-hourly, and tacrolimus 0.10% twice a day. And we continued this for over a year. Now look at how much of a change that has made. So this is a year back with all of the inflammatory markers that you saw, and this was in 1 year's time, the epithelium completely healed, inflammatory markers are gone. Then when you see the subbasal nerve plexus, what we were thinking were neuromas weren't actually neuromas. They were just cut nerve endings that looked like neuromas, and they all went away. But when we looked at her, and then her epithelium. So her epithelium here is fairly regular. I don't have the epithelium from before because we didn't have the machine at that time. And then you can see non-invasive breakup time is still abnormal. So we treated her for 6 months more. After 6 months, her OSDI improved to 11, which is absolutely normal. And she was very highly motivated. So at this time, because the nerves were okay, we were like, go through it. And once she was done, we treated her for 6 months more with tacrolimus and lubricants. And to this day, the patient is lubricant-free. It's been about 2 years. And she is more happy with her eye than she was before LASIK. So this is the importance of managing a dry eye patient. If you have someone who's come for LASIK, who's come for cataract surgery, if you are inducing more inflammation without actually treating them, they're going to have problems with corneal healing. So same thing as I said before. Then we have another case which will highlight another point in this series. So this was a 42-year-old patient. They underwent bilateral cataract extraction, had panoptics lenses inserted. Then after 1 week, she's had a panoptics, and after 1 week, she said, I can't even open my eyes. I wake up in the morning and I have incredible pain, and this subsides during the day. So the history kind of gives you a clue to what this is, right? So in the right eye, we did breakup times using the Placido disc, and you can see, if you can see closely, it's very hard to see here, but the breakups are happening, and they're happening at exactly the same location, almost the same location. Then we looked at the non-invasive breakup time, and we get it at a similar location. Then in the other eye, very similar. You can see breakups happening very similar places. So then we went and we did something called an anterior segment OCT. Here we see, this is a reference image, so this is absolutely normal. So this is the tear film on top, then epithelium, and this is Bowman's. So you can see the regular Bowman's. Then when we look at this patient, at the central level, if you can see the zoomed in image, the Bowman's is incredibly irregular. It's present somewhere, it's not present in some places, and if you go to the periphery, you can see it's like the RPE kind of clumps up. The Bowman's has clumped up, and there's no Bowman's here. So there is some problem here. Remember, the epithelium sort of anchors into the Bowman's, and without a good Bowman's, you're not going to get that anchoring. And again, similar findings in the other eye, right? So absolutely absent Bowman's here. So what was the diagnosis? We got a diagnosis of recurrent erosion syndrome secondary to some sort of dystrophy. And all we did, we placed a bandaged contact lens for 5 days, and then a preservative-free sodium hyaluronate 2 hourly with the gel nightly. And in about a month, her symptoms went away. And we continued this for 6 months, and she's fine to this day. So again, diagnosis is very important. This wasn't a dry eye case. This was actually a corneal recurrent erosion case, which sort of presented like dry eyes. Then last case, I'm just going to go through this very quickly. 25-year-old male came to the OPD with burning sensation. Again, fingernail in the right eye, which is one of the risk factors of recurrent erosion syndrome. And he had burning sensation. Again, he was also saying that it was happening in the morning. So again, we're thinking recurrent erosion syndrome. He's had surgical epithelial, and he's had surgical epithelial removal 3 to 4 times. He'd also had PTKs done to fix his recurrent erosion syndrome, but nothing was happening. So we had to figure out why was this not helping? Why was the PTK not helping? So again, we did these breakup times, and if you can see, they don't look that bad, right? There's some mild breakup happening, absolutely, but it's not happening in the same place. They're happening in different places at different times. Again, if you look at the other images, same things. Now look at the epithelium. Right eye epithelium, fairly regular, but the left eye, the one he has a problem in, hypertrophied epithelium, incredibly hypertrophied. This is not even mild. So now we're figuring out why is this happening. We did an anterior segment OCT like the last case, and you can see a regular Bowman's membrane, so no problem there. Now we did a meibography. So if you see this patient's meibomian glands are absolutely destroyed. There's some left, but most of them are gone. So this patient's problem was not recurrent erosion syndrome, even though it presented that way. This patient had severe meibomian gland dysfunction. And this is someone who's going to be incredibly hard to treat because a lot of the meibomian glands are already destroyed. So what did we do? We did hot fomentation 3 times a day, and we gave them omega-3 fatty acids, and then preservative-free sodium hyaluronate. And then hot fomentation was continued for about 6 months to a year. The patient gets gradually better, but obviously, because the meibomian glands are so destroyed, you can't make them absolutely perfect. And that's the end of my